Hello, everybody. Welcome. We're waiting for some technical solutions to the start.
Pour atteindre les objectifs 2030, zéro SIDA, zéro VIH, donc les bailleurs doivent s'impliquer. Il fallait qu'on continue à faire le dépistage, sensibiliser la population qu'il y a un danger.
C'est vraiment frustrant de voir tous ces défis qui jalonnent encore notre chemin et pour lesquels les efforts restent encore insuffisants. Sans accélération de ces efforts, mais vraiment grande accélération, même en 2030, on ne vaincra pas le VIH.
Hello, everybody. Yes, is the sound okay in the room? Yeah,
I think so.
Okay. So I'm Crystal. I'm a Deputy General Director with MSF in Brussels, and I would like to welcome everybody to this conference today, organized by MSF in collaboration with all the panelists, which will be presented to you shortly. Today, this panel will talk about the cost of a global disengagement on HIV/AIDS, the cost of it, not just in money, but for the people directly impacted. MSF has been part of the fight against HIV and AIDS in the first quarter of this century, and we have to say enormous progress was made. We, as MSF, were also outraged by the deaths and unequal access to treatment. We tested, we treated, we researched, we innovated and advocated, we bent the curves, much, much more. We also failed on the way, but we learned and got on with it, together with many others. We also documented the financial flows that were and still are crucial to curb this epidemic that killed millions. Dr. Mitt Phillips, our moderator for today, was very much part of this work in her many years with MSF as a health policy advisor, where she focused, in addition to HIV, on crisis healthcare and global health systems. She also worked at the Institute of Tropical Medicine in Antwerp, and before that spent 15 years with MSF in, amongst others, Chad, Angola, Sudan, Ethiopia, Kenya, DRC, and Cambodia. I personally had the pleasure to work with and learn from her an awful lot, and I'm so glad to see you here meet with us. Thank you to be our moderator of this very important conversation, and I pass it on to you.
Thank you very much, Crystal. Good afternoon, everybody. Good evening, good morning for those in different time zones who are joining us. I'm very happy to welcome you to this MSF talk. As Crystal was saying, it is an important topic and a very relevant topic in these times of, well, these difficult times, let's say. We will speak about the cost of this disengagement, but also how can we face this new environment, this new reality, and what should we do to adapt to it. So time is unfortunately limited. We have until 6 o'clock here, CET, but we will have to do all an effort to make the most of it. I just give you a bit of the outline of this session. After this introduction, we'll start with a little presentation on what the situation is for the moment, so that we start a bit from the same knowledge basis. And then we will go into the panel discussion. We'll ask our guests on the panel to contribute to 4 questions that I will put to them. And then there will be an opportunity for questions from the floor and from people online, so you can post them in the chat. So, but let's hold your questions until a bit later. You can write them in the chat meanwhile. And then my colleague here, Dushka, will make sure that we get the most relevant questions, and then I will hand them to the panelists. So just a bit of practicalities, like always. Turn off your mobile. People online, please make sure your microphone is muted, so that, except if you want to speak, and except for speakers, of course. So just to mention also, there is translation available. Donc si vous êtes en ligne, vous pouvez écouter la traduction simultanée en français. En u kan ook de Nederlandse vertaling volgen online. Er is in de chat zijn er instructies hoe u die kan beluisteren. Dus mag ik de sprekers... nee, I go back to English, sorry. Can I ask the speakers, the panelists that we have, to put on their camera so that people can see you and who are the panelists for this discussion. I have to my right side Stephanie Drees already, who is here in person. The 3 other panelists will be online. Ulrich, Florence, Modeste, can you please put on your camera? And I will do a short presentation of them. So we have Florence Riako Anam, who is co-executive director of the Global Network of People Living with HIV. And she dedicates her professional life, I will say, to ensure that research and policy translates into real improvements for people living with HIV. So she will be contribute from her experience in this global network, and she can provide us from many examples from many countries and this more global view. He is joined by Modeste. We don't see Modeste yet, but Modeste is executive director of HOTSAS in DRC. He's an activist and human rights defender from Bukavu, promoting health and rights of key populations. He will tell us his experience from a region in conflict and with many, many challenges, but he can also share from his exchange with other civil society organizations across Africa. Then we have also Rurik Ooms, who after MSF did lots of academic work on the right to health and global health in several institutions. And at present, he is professor in global health policy and head of the health policy unit at the Institute of Tropical Medicine in Antwerp. He will share with us his reflections on the current trends in global health. And for MSF, we have Stephanie Drees. She's the coordinator of HIV and TB advocacy. She has supported many countries where MSF teams work in HIV and TB efforts. And she has detailed knowledge about how policy changes translate in practical difficulties for patients and for health workers. So I also want to remind you that some of these examples, you can find them back in the recent MSF report, Deadly Gaps, Don't Turn Away from Saving Lives, that Stephanie contributed and others in the team. And it provides examples from different countries on what are the gaps and what are the consequences of the gaps. Link in this chat so you can go and have a look. I recommend you strongly to go and read that. So without further ado, maybe we can get started. So we have asked Stephanie, who is the coordinator for HIV and TB advocacy, to give us a short overview of the situation worldwide in terms of HIV and wider health. She will remind us what is happening right now, fresh really what is happening and what is at stake globally. Stephanie.
So I'm sorry for those who are here in the room, because we have technical issue and you might not see the presentation. So I will try to be short. I hope that online you can see it at least. Yeah, okay, great. So let's start, because we don't have a lot of time. I wanted to start. We see it. Okay. First, to discuss a bit or to explain a bit the trend in the official development assistance, that we see that it's really decreasing. You see here the 17 largest donor countries for development assistance, with the US who is at the forefront in 2024 at least, but it's really decreasing this year, and you see the projection for next year. But it's also the case for the other big donor countries, so Germany, UK, Japan, France, and the 12 others that are listed below. So you have this trend that countries are really disinvesting from the development assistance. Just to say a word about the global impact that we saw with the funding cuts that happened in beginning of this year by the US. So the context that we're heavily depending on the US funding, you see the list here, a lot of countries, so Afghanistan, South Sudan. For DRC, I put 70% is the percentage of the US support to the humanitarian response plan. So on top of that, there is also development assistance and other bilateral program that the US was providing in DRC. For Nigeria, the humanitarian response plan, it was 57% provided by the US. And for Somalia, 25% of the government budget was directly supported by the US. On the right side, you see the 26 highly exposed and highly fiscally constrained countries that will be unable to fill the gaps that will be left by the US. And you see the percentage, so the comparison between the US bilateral global health assistance in percentage as compared to what the countries directly put as health expenditure. It's massive. You see in Afghanistan, it's more than 300% difference. And just also to say a word about the affected bodies. Of course, the US agencies were the first affected, so PEPFAR for HIV and the President's emergency plan for AIDS relief, but also CDC, NIH, so the National Institute for Health, FDA, USAID, so the development agency of the US. But not only the US body were affected, it's also about the United Nations. You have heard most probably the UN 80 reform with UNFPA that might merge with UN Women, WFP that will have to merge with the FAO, UNAIDS that will sunset, so that will close by the end of 2026. And we know that UNAIDS is really important for HIV, at least, not only, but for the data globally, UNAIDS has been very important to make sure that we can have like estimates of HIV and also clear data from countries gathered in the World Report every year and so on. So in the future, it might be quite complicated. Also an impact on other global health actors like Gavi, the Vaccine Alliance, also the Global Fund to fight HIV, malaria, and TB. The US is providing 1/3 of the budget of the Global Fund, so it's a very important donor for Global Fund. And we see that, it might have a big impact, and we will discuss that a bit later. And also, of course, US was funding a lot of US-based organization, NGO or other, and partially or fully, and it had also an impact. Just to say, I will not enter too much into the details of the US cuts and the policy shift that are happening now. But what is important to know, you may have heard that the US government was shut down for 43 days. We don't have the clarity yet on the budget. So on the future, there is still a lot of uncertainty. What we know is that we don't know exactly when the budget will pass. It might be in January or maybe a bit later. We don't know yet the amounts. There is still a lot of things to be discussed. But even if the Congress is voting for an amount, it's not sure that the government will spend it. So there are a lot of question marks around the future US foreign aid policy. And then a word on the America First Global Health Strategy that will make America safer, stronger, and more prosperous. So it's not about aid anymore, it's about trade. And it's about bilateral agreement between the US and the countries. They put totally aside the support of civil society organization. They go for private sector. Faith-based organizations are the only civil society organization that they might work with in the future. The rest is really put aside. There is also imposing conditions such as anti-abortion language, not only language, because also the policy is quite strong, and the Buy American clauses. So the implementation will start by Q2 of next year. And there is also something that is quite, might be a bit challenging, is the co-finance program. So it means that country will have to participate to the response. So in the MOU, you have a chapter about HR, about lab, about commodities. So for 2026, it will be the US that will cover everything. But from 2027, the countries are asked to participate and to cover more and more every year and to arrive to 100% covered by the country by maybe in 5 years or maybe less in some cases. So it asks the question of the capacity of those countries that might be a bit limited for some of them. And also, because we are talking about HIV, so to remind everyone where we are in the HIV response, so you know that we have more than 40 million people living with HIV in the world. We still have every year 1.3 million of new people that are acquiring HIV. And regarding the people dying from AIDS-related causes, it's still 630,000 per year. So the cascade evolved in the last 20 years, and we can be happy that the progress were made in the last 20 years. You see the adults that are knowing their status, 88%, 78% are receiving treatment. But for the children, it's another story. We are still far away, and the progress are uneven in each country. So you have countries that are almost achieving 95, 95, 95. Botswana, for example, not the case of South Sudan, where you have a lot of challenges. So we know that Africa region is the most severely affected. So children, I was saying, so they represent 3.4% of the total people living with HIV in the world, but they also represent 12% of the death. And we see that the gap in the HIV treatment coverage between children and adults are growing instead of narrowing. You see the rest as well regarding the adolescents, girls, and young women, that you have like 4,000 adolescents girls that became infected with HIV every week in 2024, most of them in sub-Saharan Africa. You have regions where you have rising epidemics. It is small epidemics as compared in number, but then you have a new infection growing there. And it's primarily because there is a lack of prevention services for specific population. And also you have policies that create problems. So criminalization policies, stigmatization and discrimination that doesn't help and yeah, are very bad for the people. And then the HIV prevalence, we know that key population are more affected by HIV, 11 times more for gay men and other men who have sex with men, 4 times higher among sex workers, 10 times for people who inject drugs, and 12 times for transgender people. We know as well that there is increased level of vulnerability for people that are in conflict zone and so on. Trying to go quick. Regarding the funding, 2 big donors, PEPFAR and Global Fund, but the US is really the big elephant in the room for HIV. It represents more than 50, so PEPFAR alone, so the bilateral program of the US, represent more than 50% of the of all international funding for HIV. And Global Fund represent 28% of international funding for HIV, but the US contribute to 1/3 of Global Fund budget. So really the US is everywhere. And in 2024, the international funding represented 48% of all funding for HIV, and the rest is supposed to be covered by governments, but most of the time, it's by people themselves that have to pay to have access to the services. And this international funding is constantly decreasing since 2018. And there is a strong push more and more, and even more today with the funding cuts, for domestic resource mobilization. But I mean, there are some macro challenges. So this slide was presented by the Global Fund at ICASA conference 2 years ago, but it's still very relevant. So it talks about the macro challenge that we see in many low and middle income countries that might not be able to put more money on the table to cover more of the HIV response and malaria and TB response in the future, because of the rising debt distress, because of the issue of food security, because of the expected growth that is not there and is stalling, and the reduction of government spend. Then just a small slide about an article that was in the Lancet not so long ago regarding the risk that we see with the US funding cut. So the red dots represent the trend in the HIV death if the US stopped totally the fund for HIV. The blue is if we continue business as usual as 2024. And the green is if we do everything good to achieve the targets by 2030. I think that today we are between, or we might be between the blue and unfortunately the red. It means that we might lose the gain that we had so far regarding the death in HIV. A word on the Global Fund perspective, because there was the 8th replenishment last Friday. And before talking about the replenishment, I would like to just highlight the deallocation exercise that just happened a few months ago. So for the first time ever, Global Fund asked the country to decrease the amount spent. So they received a grant for 3 years that is covering 2024-2026. But they announced to the country that those countries don't have to spend the whole money because they didn't receive the money from the donor countries. So it means that the countries like DRC, CAR, Guinea had to review their grants to remove some activities to give back some money, so 11% in total, so from 10 to 15% between countries, to make sure that they can meet the money that they have at the global level. So it means that the countries had to pause not essential, what was called not essential activities, such as trainings, prevalence survey, equipments that were foreseen to be bought, etc. And they abandoned what was not yet in place or what was not really well working. So it means that we stop the ambitions totally. It leaves enormous gap because there were already gaps before, and now there is even more gap because they have to spend less than what was foreseen. And then regarding the GCA, so the Global Funds Cycle 8 programming, so the replenishment conference so far, they succeeded to have pledged. The amount is 10.6 billion. You see on the right, you have some donor that didn't pledge yet. So France is really waiting. And on the right, it's what they pledged the last time. So for this grant cycle, so France, for example, pledged 1.6 billion, but we are still waiting and wondering what will happen in the future. 2 minutes, okay. Just a word on what we see as cuts. So I was saying we were seeing gaps before the big US funding cuts and everything that happened this year. Just few examples there. I will pick only one or two. Regarding PMTCT, so for example, testing for pregnant women, in the current grant, Global Fund is covering only 15 provinces out of the 24 that Global Fund is supporting in Congo, who are reported far. Because there is another example for TB. Let's talk also about TB. The targets of coverage of treatment or of TB in DRC is too low as compared to the number of people they diagnose every year. It means that every year, 10%, it represents more or less when 20,000 people, even more, 23,000 people, need to wait before being put on treatment for TB because there is not enough money to buy more treatment. This is the situation that we had even before Trump decided to go for the funding cuts and everything. So this is the situation. You see some examples from South Sudan and Guinea. And then since the funding cuts and all the policy shift, what we saw is HR cuts, top of distribution of communities, the community activities that were suddenly stopped, and that had consequences for people that suddenly struggled to have access to services that are saving lives, basically. Everything linked to key population intervention were also stopped from one day to the other. The community-led monitoring, that is a key intervention to make sure that we see what is happening in the health clinic about stock out, about quality of services and so on, stopped as well, and are now excluded from the waiver, so it will not resume. We know that monitoring and evaluation system were put down. There were a lot of termination of operational research, disengagement from the support to surveys, etc., that will have longer term consequences. So it's something that we don't see now, but in few months or in few years, we'll just become blind and we will not know what is happening in the HIV response and how to adapt best the response. So this is a huge problem. 56% of the HIV grants in PEPFAR were terminated, and the rest was a bit problematic to resume. Some of the organization didn't have the means to resume while the funding was not there and so on. So it was really chaotic, and it's still today. And then further cuts happened due to the deallocation exercise. Last slide. Yeah, the trends and the risks. So there are still a lot of uncertainty, but what we know today is that there will be definitely less money, fewer actors. We see a loss of ambition. So really, we can, when we discuss with Global Fund country teams about the future and so on, we can feel the loss of ambition, and also the question about maybe are we going to maintain the gains that we have today, or is it also something that we are ready to lose? And yeah, we will do what we can, but that's it. It's really a question mark. And then, of course, the strong push for domestic resource mobilization. Of course, there is a need for countries to put more money on the table for their response, but to what extent it is feasible in the timeline that we have, so from one day to the other, to cover the gaps might be complicated. So the big risk is to have a re-emerging epidemic. Yeah, and I will stop here. The rest you can read maybe too. Yeah, thanks.
Thank you, Stephanie. It's quite a challenge to bring all this information in the short time we have, but I think you did very well. And people can afterwards also look it up still. But yeah, definitely this disengagement of international aid, and especially in global health, has an important impact also on HIV. We see already there is impact on people's health care and health itself, especially as these gaps that have now been extra created. It is only the question if there can be some compensation by domestic resource mobilization. This is the dominant narrative. Countries have to do it themselves, but it is absolutely unclear then how they can or should do that. And we'll have to wait how this turns out. So much of the expected evolution is still unknown, I would say, and there is a lot of flux. So our discussion on how to adapt to those changes, it's not easy at all. But we'll start with our panelists. Maybe they can help us to get some ideas and some suggestions. I also wanted to say that what you are mentioned, it's clear there is global effects, and then there is certain countries, certain people, certain activities that will suffer more than others. It will be very uneven, and people who are in fragile situation, in vulnerable situations, are likely to have more barriers and problems to get the adequate care. And therefore, people living with HIV within this whole global health evolution will be especially hit by this, and we need adapted strategies to face this new normal. So let me see if we can turn to the panelists and see a bit what is their ideas about this new normal. How clear is it for them? How can we resist it still? Or is adaptation the only possibility, only option left? What is your experience and your vision about this new normal? And what changes do you already see in your work? And which one do you expect? Do you have specific concerns? Do you have some risks, specific risks that you see? And in the immediate term, but also in the longer term. So maybe I can start with asking Florence. Florence, could you give a bit your ideas around that?
Indeed, and I want to start by saying thank you for having me here. Can you hear me okay?
Yes, we hear you 5 on 5.
Perfect. I'm sort of internalizing what you just said now, and I'll speak a bit, and I hope I get to answer a couple of your questions now. I think for GNP Plus, I must add that because we sit we do a lot of analysis in the global space, and we were the civil society co-conveners for the high-level meeting on HIV in 2021. GNP Plus also has a non-state actor relationship and status with WHO. So we were in the middle of the World Health Assembly agenda item to conclude on the global health sector strategy on HIV, STIs, hepatitis in 2022. We had already somehow anticipated a shake in 2025, and if it won't be significant, then it will be in 2028. And had begun to ask a couple of questions to ourselves, to reorganize, to rethink what would be important. But I think going into January 21st, a few of the things that we sort of thought would be with us became true, but to the magnitude we didn't prepare for or never thought possible. I just wanted to start that because then it will make a sense of how I'm probably going to answer a lot of the questions now, because I think we've this year, GNP Plus, my leadership with Bongile Nkosi, my co-ED, has been a little bit on the push for people living with HIV to lead, because we have believed that this is when we will need that leadership the most. So drawing from that, we quickly reorganized ourselves as we had planned to convene a lot this year and turned those spaces into understanding what's going on at country level. And I must say the first meeting which we had, which was on the last week of January, DRC, Nigeria, and Uganda showed up with some very sophisticated slides of the actual impact, particularly of community cadres let go, names, different departments, districts or states, etc. For DRC, we even knew how much ARVs were left for which facility. And we had to ask them, where do you get this information from? And they said it's from their government. And so we quickly learned of this unique relationship that people living with HIV networks, particularly in the countries that are hardest hit by this financial decision by the US, have with their governments. And we have motivated ourselves to ensure that that relationship keeps and stays going. And it has enabled us to know a lot of what's going on and to participate with the governments in defining priorities, in sort of calming down panicked, because for us, people were panicking and writing and asking, what do we do? Because there's a lot also of misinformation. We like to say we didn't have the luxury of thinking what we should do or resisting or what. We just had to launch to make sure that people are not moved away from their services. We had people waking up on 21st and their clinic appointments could not be realized. People didn't have treatment. Over time, we've learned of a lot of other things. When we held our PLHIV Leadership Summit in April, which brought government, partners, donors, media, everyone together, we learned now the depth of this disruption, the fact that data was all gone, the fact that the issue with us not probably getting our monthly supply, 6 monthly supply was not because of lack of supply, but because there was no data or no human resources for health for HIV to service us. We also learned the magnitude of how vertical HIV was. Many of our community health workers were let go. We saw immunization, for instance, and others, the community health workers who are within the government community health departments of community health services were continuing with their work. The HIV ones could not. So these realities have also shifted a little bit of how we think of what is the actual problem and how we should move forward, moving on. And I will discuss a little bit more as we continue. What I want to highlight is UNAIDS released the World AIDS Day report yesterday. It's really shared detailed impact of this disruption to people over time until now. I think there was the waiver and a few other services did come back. But what I want to point out is that that was within the COP period that ended on September 30th. So from October 1st, many networks lost staff. Many of them have had to lose peer support services and engage with different things. But I like chapter 2 of that report, which is where I think we've shared a lot about what the networks have been doing, because we've also seen demonstrable resilience between governments coming together regionally, governments working together with whatever they have to try and bridge this gap. We've also, and I've seen that conversation shifting and changing a lot at IAS. There were pre-conferences on how do we bridge the gap on prevention and make prevention a public health issue. The language of governments is changed and different. At World Health Summit, I attended a breakfast organized by UNAIDS Unite, Stop AIDS, and the conversation was about this aid and what would governments need, and none of them asked for money for HIV. They asked for support to be able to address corruption. So I think we need to figure out where we are at and have a good grasp of where we are at. And I think, in my view, there's a very big disconnect, which I'm finding a risk, a big disconnect between the global space and the country realities, and countries are moving faster, and we might lose the multilateralism even further than it is now.
Okay, thank you, Florence. Modeste, can you maybe from your country perspective add a bit on to this?
Oui, merci beaucoup de nous offrir cet espace qui nous permettra, n'est-ce pas, de vous...
So, I don't know, Modeste, sorry. Yeah, so we're very happy to have you here, but can you switch to English for the translation, for the translators, please? Huh? Because the translators...
Ok, je vais essayer. Je vais essayer.
Je sais que vous êtes très fluent.
So, thank you very much for giving to us this opportunity to with you all about the context of DRC exactly. As you know, sorry, I must cut the voice from the interpreter. Sorry, let me. I don't know what to do. Okay, it's okay. I was saying, I think it's okay now. It's important for different organizations, different leaders, different stakeholders to discuss, to exchange about this situation. You know, the lack of USAID funds was affected seriously DRC, because we receive around 70% from USAID, and this 70% from USAID help many area of HIV programs, HIV/AIDS programs. First of all, at Bukavu, for example, we have 672 persons who are living with HIV who are on treatment. And we have just one center, Centre Boigna. It's a one center who provides treatment for people who are for the person who are living with HIV. Secondly, we are in the context of war, since February, east of DRC, rebels group was decided to keep it this part of countries. And the governments have the biggest problem to face it to this situation, security situation. In this context, it became, we can say, double challenges for persons living with HIV, for activists, for organization, even for hospital center who provides care and treatment. The information that we have for now, we have the biggest problem. Lack of the test of HIV. We don't have test since May. Since May, we don't have test at the east of DRC. We have also problem with ARVs in the second line. We don't have a second line ARVs. We don't have also ARVs, pediatric ARVs. That also is a problem. We have also a problem with PEP. We don't have PEP. Even the PEP, we don't have since May 2025. Condoms also. The condoms, the part of condoms we have, it's just for the center, but not for sensitization, not for different activities on the ground. That is for HIV. For TB, we have a problem with, I don't know what to call it in English, seringa faible espace. It's a, I don't know how they call it, 4 to 5 seringa. I don't know what they call it in English. We have a problem with medicine about treatment of TB. Those contexts, it's very, very difficult for us. We're discussing about it. As you know, I'm one of members of GFINE, Global Fund Advocacy Network. I interact also with different organizations in French country speaking, West and Central Africa. For now, I'm a vice president at Task Force of Key Population in Africa, East Africa. We're discussing a lot to know exactly which kind of strategy we must put in place, because the lack of USAID, the decision of Trump, but also that affects also Global Fund. Global Fund was the biggest, one of biggest funds for HIV/AIDS programs in Africa, in the DRC. We were discussing a lot with different actors in Africa, with different stakeholders, with different partners, to know which kind of strategy we must put in place. Because the lack of funds, we must see how to continue to prove how people, key population, who need PEP, key population, who need treatment, but community also, ARVs, they need also ARVs, how we must continue to provide to them. I don't know if I can share with you the strategy we are discussing about it. We are thinking that it will be nice for us to mobilize local funds. It will be nice to mobilize local funds, but how to mobilize local funds, that's a problem. How to mobilize it. DRC was one of countries who we want to make a first experience. Unfortunately, the war was arrived, unfortunately. But the experience was to make a best advocacy programs, advocacy programs to mineral mining, enterprise. Because at the DRC, we have many enterprises from many mineral enterprise. at Katanga in south of DRC, at South Kivu, North Kivu also. We have many in Central Africa, Central of DRC, we have many enterprise, mineral enterprise. Why not contact them? Why we cannot contact them with the national program to explain to them they must, because they are paying money to the government. Why not they can pay, they can support in local with the government? It would be nice to do it with the government. How we can do, which kind of strategy, advocacy strategy to explain it to those enterprises to support how we can do it. But there are also we face too many challenges again, unfortunately. The biggest problem is the redevability. I don't know what to say it in English. The redevability.
Yeah, we'll go a bit further into what kind of possibilities there are.
In Africa, many governments, their health politics, it's just for to be leaders, to be politics, but it's not just to be politics, but to make a program, a best program for community, that is a challenge. And sometimes when even global funds support the DRC around $500,000 by seven refreshments. I can imagine. Yes, seven refreshments of global fund. But many of this money, if you see the report of DRC, the problem, it's a challenges. We have a problem with Minister of Health, I don't know, it's a politics, How to use this money from those people, those organizations, those leaders. We have many musicians who have millions, who are the billionaires in DRC. We have some people who have, they want to say, the big enterprise around the world. How to meet them, how to discuss with them, to support HIV. That's a local, a local finance, how to mobilize local finance. That is one of strategy we was in the beginning to put it in place. Unfortunately, the war was coming. Automatically, the war was broken. All programs at DRC, as you know, for now I must leave because here we are in the zone where MSF must close because I'd like to thank also MSF because they was giving to me the place here in the office of MSF and the network and the connection, because to be just connected, it's a challenge for us, it's a challenge. We are obliged to use, for example, at Rwanda network or South Africa network. Can you imagine? Thank you for MSF to giving to me this opportunity, the office. And secondly, to talk about this. That's a summary for that I can say. I think I will have something to explain about it.
Okay.
Thank you.
Thank you, Modest, for sharing a bit the realities on the ground and of some of these challenges that are likely to become worse with the current evolution of things. So now I would like to ask Horik to see what is his experience and vision on this new normal and what concerns he has.
Well, I think a lot has been said already, but I'm trying as an academic to bring some structure to it. And it's very difficult. I mean, since the extremely bad news of January, we've been on a roller coaster of contradicting information. And one week it's this, and the next week it's that. And then things stop, and then things resume again. And this week I was relieved to see that the US contribution to the Global Fund is confirmed. But it may be very misleading to go on these emotional roller coaster and think after all, it's not that bad. I think it's bad. And I tried to write 5 different scenarios. They're not completely different, to make it also clear for ourselves, like, okay, what should we be preparing for? I think the best case scenario is still a bad scenario. The best case scenario is now what is the dominant language of, I would say, African politicians. Yes, we will adapt, we will integrate, Accra reset, finally, we will take our responsibility, etc. So the first scenario is a swift integration, taking over those programs by ministries of health and governments. Even in this scenario, there will be victims. Victims will be men having sex with men, sex workers, people injecting drugs, other marginalized groups, even in the best case scenario. And we knew this. I did a study on this like 7 or 8 years ago, sometimes with unexpected things, but women who run away from their husband in Indonesia do not have the right papers to get health insurance and are therefore not included in the national health system. And in every country, you will have certain groups like that. And so that's the best case scenario. It's not a good one. And honestly, I think it's a bit unlikely. It's a bit wishful thinking. The second scenario is an integration with serious hiccups. Let's not forget the US money was not only paying for medicines, it was also paying for a lot of technical assistance. And that is not going to come back with the America First strategy. A lot of that is already lost and will not come back. I think there was a fair argument that these vertical systems, parallel systems, etc., were somewhat exaggerated, that more effort was needed for integration, but there was also a reason why they were not integrated in the first place, and that is because in some countries the health systems were simply too weak. Now that may have changed over 20 years in some countries, but not in other countries. So I think the second scenario is that in some countries there will be serious hiccups and stockouts and people will be excluded from treatment. The third scenario is a bit in relation to that, that countries decide themselves in this integration to go for a simplification of services and decide not to test and treat immediately, but to test and then wait and go back to the old way of doing with CD4 counts and viral loads. And at some point, there may also be choices made like, we're not going to do viral load anymore because that's too complicated and that's too expensive. And let's go to the cheaper tests that we have. And one I seriously fear, but because it was suggested in 2001, and maybe I should have said that in 2000 and 2001, I was working for MSF in Mozambique and I was involved in the setting up of the AIDS treatment programs. There was a suggestion at that time by people in the World Bank to increase co-payments and make people pay for tests and at least a certain percentage of the price of medicine. And the real reason was to reduce demand, was to exclude some people, and it was a strategy aiming at keeping civil servants alive, people with a salary who would be able to pay, and not extending treatment to other people. This is something I fear we may see coming back. A fourth scenario, which again is not completely different, I think some countries will not sign with the US. This America First negotiations, we don't know all the details of it, but they go very far. They go into education. What are you educating on sexual orientation and gender? Is abortion legal in your country? But also on minerals, also on sharing pathogens. I mean, these negotiations are completely derailing the ongoing discussions on the pandemic agreement and the pathogen access and benefit sharing. I suspect that some, probably not the low-income countries, they don't really have a choice, but some lower middle income countries may decide not to sign or may not come to an agreement. And that will then reinforce the problem of the third scenario, that further simplification and with co-payments. And then there's a fifth scenario, which seems a bit unlikely, but I think we should consider it anyhow, that this whole America First strategy is not very serious and is a way of shifting the blame, of saying, okay, you blamed us for abandoning so many people. Well, we tried to negotiate with those countries. We gave them like 5 years to take over the whole financing, which we know is not possible. And then now we can pull out again, but now we have at least shown that we were willing. I don't think it's very likely, but with this administration, we've seen so many things that it's not something to exclude. Now, what do we do with that? I think a number of points. And the first one I want to make is, let's not give up on UNAIDS. It's not finally decided yet that it will stop in 2026. Even in the best case scenario, we're going to need UNAIDS to help civil society organizations, to help marginalized people. So I think we need to increase the pressure on that. I think for NGOs like MSF who can afford it, is to really support local NGOs, and not just by giving them a place in the office to come and do this video conference, but also with financial contributions and go beyond that. And we've worked with them in 2000, 2001, 2002. They helped us. It's time for us to help them. And I think prepare for a major health system overload. In some countries, it's difficult to predict where, but there are millions of people who are at risk of not getting treatment, and they will do what they did in 2000. In 2000 in Mozambique, hospitals, health centers were overcrowded with people with full-blown AIDS trying to get some treatment for opportunistic infections. I think we will see that again. And therefore, my main point is, MSF, please get back in that game. It's really needed. And I'll stop there.
Okay, yes, thanks, Gorik. So I know that Modest has to leave us soon. He has already shared with us some of his views on opportunities maybe for domestic resource mobilization. You spoke about diversification towards enterprises in the extraction industry, for example. So I think one of the things is really difficult to foresee how this narrative of domestic resources going to compensate and to be really boosted, how that is going to happen. I know that Florence has some specific ideas around that, so I would like to invite you, Florence, to comment on that.
I do? Okay. So I think for us, it's having looked at the MOU discussions, I just want to say my understanding of there are 22 countries right now doing the G2G conversations with their government. We've tried to check in with the national PLHIV networks. Only one PLHIV network has a person living with HIV in the country delegation, but even the engagement is still at like a second layer because the conversations are happening at ministerial level. I think for us, we are being a little bit forward thinking, and I saw a question earlier asking, do we resist or not? And we are being a little bit strategic in understanding there are things we can resist, but there's a strategicness about how we can be adaptive in a way that makes sense ahead. There are things that are moving faster than we can catch up, and we have to understand that. So these conversations, as we sit as people living with HIV, we already know that when the condition of the MOU is that the government must have a commitment for domestic financing and no extra donor funding or or partnership funding does not constitute that commitment. So it means whether we want to or not, even if we do, because the MOU is up to 2030, we are going towards an environment from which we have to pay for HIV services at some point. And so we are sitting here and looking at what those realistically look like. There are people who, we are listening also to governments who are shifting. Zimbabwe, for instance, is on it right now, and they've been very clear in saying they are adapting their act of parliament that constituted, for instance, the National AIDS Control Council to change it to the National Health Council. So things are moving more towards broader health. If you look at the UNAIDS Primer Part B, which governments are now doing as part of the HIV response roadmaps, which was the plan set up before the Trump's administration. So we already knew we're in a transition process. This situation has just caused confusion with it. Is also looking to sunset some departments like the NACs and everything else that have been supportive for these multi-sectoral convenings. Currently, governments are insisting, even if you want to do donor-supported projects, they have to be instituted within government processes. So we are looking at these boxes that continue to sort of hold this and that. And with networks, we are thinking of different mechanisms that we can engage with, whether it's social contracting, but also using opportunities of thinking, how can we work with our governments? Many of them have not been putting HIV in national health insurance programs. So taking national health insurance, HIV back into national health insurance programs and having an understanding of what that is and what mechanisms would exist. How do we figure out a mechanism and because, sorry, I'm leaning a little bit towards Africa, but because that's the most hardest hit region and that will shape a lot of what will happen in the future, Africa's private sector health service delivery system is largely at the primary healthcare level. It's the little family clinics many people, particularly with NCDs, go to so that they don't have to go to the public health facilities because of its magnitude of challenges. But I mean, if you sit now and look at the population of people living with HIV, largely most of those are already seeking NCD services. So how do we tap into the opportunities of these services to ensure that there is some way, shape, or form of integrating and merging services in a way that for those who can be able to pay, there is a continuity of opportunities like microinsurance, microfinancing, so that there's the holistic person-centered care for health and not just the actual looking at a person living with HIV just needing services or the communities generally needing prevention. So I think there's a lot of networks are thinking a lot of sustainability plans with social enterprising. Again, Africa is a very rich social enterprise, has a very rich social enterprise culture with institutions right now and investment into these things. So how do we tap into those opportunities, knowing what we've got? We are at the foundation of the HIV response. Many of these networks have databases with information. How can we use that to support our people to stay on treatment? So it's going to be a lot of different things. But I think the most important one, which I'm going to say, Gorik, thank you for saying that. What we are lacking right now is policy advocates. If there's anything that MSF would need to support communities with, is an investment into policy advocates. We are the same people who have engaged with very complicated Global Fund, PEPFAR, and all of these other processes, but there was investment in teaching us those processes and allowing us to understand the mechanisms for how they exist. It's shameful that we have the people with that skill set, but we don't have the same level of skill set to understand how our government budgets its budgetary framework. Yeah. What laws of parliament would be needed to support domestic financing for health, but also for HIV, and that would be needed as well moving forward.
Okay, and of course, one of the important questions will be, can this domestic, not only resource mobilization, but responsiveness to the HIV epidemic, can it also meaningfully include key populations, for example, because we know that is one of the issues in many countries. Huh? Modeste, do you want to add still a last point on that specific protection of people living with HIV and key populations?
So I must leave, but I will continue to be connected.
Okay.
Connected. Give me just the time. What to say? 20 minutes the time to arrive at home, and I will come back to. I will be.
Okay. Fine. Yeah, we'll see. Thank you very much for joining us, and we'll be further discussing this later on, I'm sure. So let me then just, so I think the point of the key populations and the marginalized populations is very clear for most people. And so in this shift, that will be one of the challenges to ensure that. So as we are running a bit out of time, we're running over time like usual, but because as we are in Belgium, I would like to raise specifically the question about the role for international actors. It could be actors like MSF that need to adapt to the changing landscape, and there is quite a bit of discussions on that ongoing, probably also in other international organizations. But also, what would we expect from Belgium? To make sure that HIV, the response to HIV is maintained and reinforced in critical areas, in priority areas. So maybe, Gorik, can you share a bit what you see as what is the key role and added value of international actors within all this?
That's a good one. I mean, I already mentioned UNAIDS. I was very much afraid that this Monday that there would be further cuts to the Belgian Development Cooperation budget. Fortunately, that didn't happen, but we're not sure. I think for me, this is a real dilemma. I have always advocated for the right to health being a human right, and therefore the corresponding obligation falling on humanity. I'm not sure that in the current political climate in Europe, that argument still has a lot of traction. I think we have to start reminding people, taxpayers in Belgium and Europe, that in the long term, this is becoming a problem for them as well. And it's a little bit complex and it sounds a bit cynical. But what do people do when they do not have access to antiretroviral therapy anymore or not regularly? They will get opportunistic infections. They will start taking some antibiotics they can find. They will be substandard. They may not complete the course. We are, in effect, creating a wave, a tsunami of AMR, which is going to come to Europe, at least part of it. This will take time. This kind of arguments that appeal more to the sense of, okay, we have a common interest here. And it's not an argument that I like with my heart, but with my mind, I'm thinking maybe we should have this kind of arguments as well.
So you think that Belgian government will be, well, susceptible to be scared with AMR on the long term, and then, well, hopefully do something now, because that's what we need.
Okay, this is becoming a bit technical perhaps, but in a way it is strange that global health is usually a discussion with people of the Ministry of Foreign Affairs of rich countries and Minister of Health of poor countries. What is happening now in some discussions is that ministries of health are disagreeing with what ministries of foreign affairs are doing. And there was a very clear and almost absurd example of that. In Germany, in Hamburg, they found polio in sewage water. And immediately, or a couple of days after, they again increased the German contribution to the polio eradication effort.
Yeah.
From a public health perspective, this doesn't make a lot of sense. I mean, this is not how you eradicate polio and how you, but you see that ministries of health are becoming more receptive to this kind of arguments, and that they are aware that this is going to be a problem in the long run. So I can't speak for governments, but I know that in different ministries of health, yes, there is some concern about this. Now, this is a really a long-term strategy. This is not going to help us for next year.
It has to be seen because, of course, it's maybe question. I think there is a trend already in international aid, definitely, that it is like Stephanie was saying, it's not aid, but trade or other interests, self-serving interest. So to use those arguments, it can be a kind of, reality that we want to use or not to exclude. But of course, it raises a lot of questions on, the disappearance of solidarity, international solidarity with all these needs that are increasing with the polio crisis. So
as I said, it's not an argument that I like, but the weak version of solidarity is charity. And what we see now is that a lot of these efforts are in fact charity. And that if at some point the rich countries decide, well, we don't want to do it anymore, they don't need a lot of excuses or arguments to justify. And if I have to make a choice between charity and win-win cooperation, you see where I'm coming from? But you know me, it's not the argument that I like to make.
Yeah. So Florence, do you have a message for the Belgian government and people here? What is really important to continue to support and to enhance?
I think I will speak again with my bias for people living with HIV, but I think it covers key populations because people living with HIV are diverse. Two things. I think one, and I just want to start from there, I believe the role of WHO, particularly in organizing normative guidance for public health, will be appreciated no matter what happens, I believe, in some way, shape, or form. And I think we must have some, ideally, because, and I'm saying this because we have sat down here and looked at every possible scenario. And for us, whatever scenario we are in, the only thing we then have to just make sure we get is our treatment in whatever way, shape, or form. So how will that happen? Then it becomes where the normative guidance will sit, because countries will listen to that normative guidance. Where the US sits with that is still something else. But I think for me, so whatever they are proposing for prioritizing and their guidance around how to prioritize in these times is being adopted a lot by the decisions of Global Fund and of all these conversations we are currently having. The second one, I think UNAIDS is an important player and will be needed in whatever transformative realities it turns into. So I don't foresee like a collapse of as an opportunity that brings all UN players into the HIV response. However, I do believe that there are other instruments that have been created over time to support funding, and particularly have been useful to support funding that directly goes to key populations and marginalized population. The Robert Carr Fund has been set up, and I think there's like some agreement on a matching that is done through the Global Fund and other partners. It's been useful to support particularly co-funding, which most networks never have. It supports our work for advocacy, and even in this disruption has been, I think, the only funder that has held global and regional networks. And through that support, we've been able to support country networks to stay. So I think identifying innovative ways of keeping the community component will be critical and important. And again, I think networks have also grown, and we are not dealing with the organizations that were, some of them have really grown, or there are mechanisms at country level that bring civil society together, not in a vertical disease program like type of way, but in groups so that everyone is able to come together and work for public health in country. So identifying opportunities for that, ring fencing, financial support in these conversations that goes to support much needed differentiated service delivery, which we know was high impact for HIV outcomes. Things like that would be important for governments with their political, social capital to be able to secure in these discussions for communities and for people living with HIV.
Oh, thank you for a very clear priority list. I'll ask Stephanie also.
Thank you. Just to add on what was said, I think that, yeah, Belgium and the other countries other than US in the world need to fight against the narrative that is being put forward by the US. I'm thinking about the women that are under attack with the SRH narrative and the anti-abortion laws, everything linked to the key population. We talked about it. I think that countries like Belgium can try to counterbalance a bit what is happening now. And it's important that Belgium with other countries try to support the programs that are being put aside totally. We know that Global Fund will continue to support key population, but there are big gaps being left by PEPFAR for key populations. And Modeste was talking about the fact that the condoms are not available outside of the clinics and so on. So there are a lot of gaps around that. So I think that fight the narrative and find where we can still support those that will be the most marginalized. I totally agree with what was being said about UNAIDS. We still need UNAIDS for the future. So Belgium also has a role to play to make sure that UNAIDS doesn't disappear tomorrow. And also to make sure that civil society organization, I really believe that it's the solution. So we need to go more in low and middle income countries. We know that the health systems are sometimes struggling to really give access to service to people. So going more in the community, with the community, by the community, it's the way forward in very challenging environment. So we need to go in that direction and make sure that we can have task shifting models of care that are adapted to the needs of the people. There are still a lot of work to be done to make sure that people everywhere have access to everything. But I think we can make it, but we will need to make sure that we mobilize everyone behind.
Thank you, Stephanie. So I have very good news. We get 10 minutes extra so that we can make sure that we will have also some questions from the floor and from online. And our panelists, if they can stick around still a bit also to answer that. So, do you want to?
I can do that indeed. Thank you. We have some questions online. The first one, which is followed by a second, is do we know even approximatively the contribution of Belgium in the battle against HIV abroad, so internationally? Followed by a second question by the same person. Can we count on the EU to, in a way or another, bridge the gaps? That was a question that was asked in the very beginning of the conversation. Maybe I can ask that too.
Yes, who could answer on Belgium? Do you?
I can start, maybe Corik after can complete. Regarding Belgian support to HIV, it's mostly through Global Fund. So I was talking about the Global Fund replenishment. Global Fund announced a pledge of 40 million, but it's for 4 years and not 3 years. Usually the countries are pledging for 3 years, but okay, maybe because of our government and they pledge for 4 years. It means 10 million per year. And last time, I think that it was 40 million for 3 years. So it's a decrease. So it's a bit disinvestment from HIV. I'm not sure that we are giving a lot of support outside of this. I think that many programs disappeared in the last years, and many countries as well focus their support through Global Fund. Germany, for example, they had some bilateral programs in the past, but they decided to close them and to give all the support to the Global Fund. And I think it's the same for Belgium. And then for EU, I don't think that EU will bridge the gap. You know, the situation regarding European countries. I was talking about the ODA in the beginning, so Germany, France, and so on. They go in the same direction as the decrease. So the European Commission, they didn't pledge yet, because the European Commission, on top of the European countries, are also giving money to Global Fund. They didn't give the amount yet, but we don't expect a very nice pledge.
Correct. Do you have specific info to add?
Maybe just a remark that maybe we have to start talking in percentages of GDP instead of in millions, because this looks like enormous amounts that are needed and that we cannot afford. And of course, we need to pay for, we have drones over our airport and we need to pay for that. Typically, high-income countries are spending at least 5% of GDP on health. That's government health expenditure. That's public expenditure. I'm not even counting the private health expenditure. If 1% of that would be used for global efforts, we're talking about 0.05% of GDP. We would have more than enough money for a complete replenishment of the Global Fund, of Gavi, of the Pandemic Fund, of WHO, and we would still have plenty of money left. I don't know if that is helpful, but I think it's important also to work with those kind of figures and compare it. It's not that much money. Making predictions on the exact contribution, I don't have the exact data, and actually it's not really known. We know that in the multi-year budget, there is no decrease for development assistance foreseen, not more than the 25% already agreed. But then in between those lines, we don't really know. Will it be more multilateral or for NGOs, etc.? I think nobody really knows exactly where this is going.
Florence, specific recommendations to Belgium?
Beyond what I said earlier, I think I would like to give a little bit
on the question of it's on the question from the public, saying how much are we giving now and to what, really?
Can I sort of offer what I think would be useful for Belgium, I think, or any leader I feel at this moment? I think we need, from our end, we need to define a public health political argument for why we need money. I think it's the humanitarian component is getting pushed back. The people are going into my country first, my people first kind of agenda. And I sort of feel like a little bit what Gorik said earlier, but I think from our end, we are also struggling to ask for what does it matter for people? Multilateralism has been getting a loss of attention and interest over time, and people are becoming very desensitized to pain and arguments towards that. So if it's a trade conversation, what then public health trade arguments must we make that then put people with it, but also tries to appease to the financials? Because I feel like for Europe, generally, we've been seeing the reduction to going down. And I know we say we believe in UNAIDS, but frankly, not been able to meet its budget for the last 3 years. The contributions have never been met. The pledges never get to them on time. So I think that has also been a demonstration of where the political will is going.
Yeah, the point on UNAIDS, I just want to remind people that Belgium has been an important funding source for UNAIDS, and they have the really strong partnership. So I think that is something that should continue, hopefully. And if I can just add on what Stephanie said about the Global Fund, it is really a problem because at the moment, the pledges of the different European member states, the Commission, and so on, let's say the other countries than the US, are for the moment insufficient to deblock the complete US allocation they have given. And I think that would be a really important target, that at least that we can use fully the US allocations, that is legally can only be 1/3 of the Global Fund financing. So we need the 2/3 by the other donors to be really fulfilled.
Yes, I still have some questions online, and then maybe also ask for those who are present with us if they have questions. But following on what we were just saying, I have one here. Out of the 10.6 billion pledge, if ever paid, how much should go to commodities, treatment, tests, and prevention, and how much to running costs? What effort is made to decrease or integrate running costs and preserve commodities?
So just to say, running costs means the functioning and not necessarily like investment in infrastructure. This was previously in old times. It was really a breakthrough that the Global Fund and also PEPFAR is paying for running costs, including for commodities, medicines, and so on, and HR cost, which was not the case before. Huh? So Stephanie, maybe.
So in the current grant that we have, so the GC7, the grant cycle 7, usually most of the grants in many countries, commodities represent maximum 70 to 80% of the total grants, and the rest is being kept for other activities like trainings, running costs, and other. So I was talking about the deallocation exercise. This deallocation exercise, of course, had an impact on that. They try to preserve as much as they could the commodities. So far, we still have ARVs, we still have malaria treatment, TB treatment, and so on. But some of the activities that were not yet implemented, for example, the advanced HIV disease package in Central African Republic, it took a bit of time, to put in place. So nothing is really implemented yet. Because they had to cut somewhere, they decided to cut this because it's not working yet, it's not existing yet. So we put that aside. So it means that we will never see, maybe, or at least not for the next 2 years to come, the advanced HIV disease package for the people who are sick and present to hospitals. So voilà. So that's the situation that we have today. But for sure, in the future, if the Global Fund has less money, the commodities are the thing they will first preserve. So the ART is the medicines that will disappear the last. But it doesn't mean that it will then create no problem, because in many countries, so I just gave the example of CAR, but you have also South Sudan, DRC. I mean, we still need to implement new models, new strategies to make sure that people can have access to testing and treatment and all the rest of services. So, yeah.
Yeah, Florence or Gorik. Modeste is back also with us.
Just what Stephanie said, I think I'll give an example of a couple of countries. Kenya, for instance, 40% of the treatment is US, 40% is Global Fund. Kenya pays 20%, and that's where they will put the money. But that doesn't cater for I think that's what you're calling the running costs. But if you look at countries like DRC, for instance, or others, even mine included, so that doesn't cover for second line or pediatric, or for some countries also challenges with viral load. So the additional complementary services that were there, for instance, also screening for cervical cancer, which had been embedded into HIV care, for places where there was NCDs also integrated within HIV care. So for those, we are already starting to notice people are paying. I'll use my own example. I go to a clinic that is a level 2 clinic that was a PEPFAR supported clinic. For the last almost 5 or so years, we have been paying 100 shillings to access our files and see the doctor and get all the services for free. But when I went back, I was there in January, slightly before everything changed. And when I went back, I had to repeat my viral load because they'd lost their results, but I had to pay 500. So see, that amount has increased 5-fold. So again, now you see that will challenge whether many people, even as it is, it's a level 2 facility in the middle of the villages. It's not easy for people to afford that 100 bob. So now it's 500. So these are the realities that these present.
Yeah, so if we agree that AFT and other commodities are really the backbone of many of the HIV programs, you need quite a lot of other support to make sure that these commodities can benefit people and patients. No HR or no community approaches or the stopping civil society support that might really have a very negative impact on results in terms of life saved and also on disease. One more question?
Yes, maybe one more question online also. Zimbabwe have imposed AIDS levy, is that the right levy? 3% on personal and corporate profits. Could this be replicated elsewhere?
Yeah, I think Florence mentioned it already. So this is the HIV levy that was, I think it's now 10 years ago already applied. And that is now being changed into a kind of more health, a wider aspect. Well, Gorik, maybe do you have comments on that one, or don't need to? But
well, when it started, I think it's even older than 10 years. The first discussion started already in 2005, 2006. In itself, it's a good idea, but for me, there's a bigger discussion that we need to have, or that I fear. People who are as old as me or older will remember that in the 80s and the 90s, if you wanted to get money for a project, you had to have, from the beginning, an exit strategy. That was the so-called sustainability at that time. We were not talking about climate, etc. Sustainability was, if you create a water pump, you have to be sure that the community can take it over, etc. And we may have forgotten that AIDS changed that logic completely. I really fear when I see comments from people like Mark Dybel and others about sunsetting the global fund, and that it's about time to go. I mean, sunsetting is a nice word to say we're going to stop it. And I think this is what we need to counter, and to say, okay, yes, there has to be a discussion on what the domestic contribution has to be, because some countries could indeed do more and should do more, but it's not one or the other. It's not, let's stop the international funding to put more pressure at the national level. For some low-income countries, we know that the response, the appropriate response, is still too expensive. And so this health sovereignty and this kind of language is something that, in one way I appreciate it, and I think it has a good side, but it also has a very, very risky side of legitimizing the ending of solidarity.
Yeah, I think Modeste might be able to say also something about the possibilities of creating such funds in countries or contexts that have many other challenges. Modeste, would you think that for you and the key populations, this could be a good piste, let's say, to explore? Oh, you are on mute, sorry.
Yes, I think yes, I was in the chat. If you can check in the chat box, I will send some recommendation. Huh? I was sending some recommendation to MSF and also to Belgium. But for me, it's important for civil society Africa. That is important. For civil society Africa, I think it's important. It's time to responsibility our government to take care of people. It's time. How to arrive to this context? I think that's we need group. We need. I think it would be nice for international organization, for UN agency of UN nation. It's also important for African, what to say, European Union. Yes, for European Union, I was looking at it. It's also nice now to support civil society, to accompany civil society, to push those governments. At the DRC, we need peace, for example. We need peace. It's not how we can help without peace. We need peace. That's a problem. I think it will be nice because you cannot. Now I'm coming from MSF, but we are going quickly. You cannot imagine because and the whole staff of MSF was going quickly just because the context is not good. How to face it to help without peace? That's the first problem. We need MSF. Don't just that Gorik was saying. Thank you, Gorik, for mentioning this. It's not just to use the office of Belgium. Please, can you support us to our strategy, to our activities that will help to attend 2030? Because if the community is not involved, to participate, to integrate, to activate, to work in the program, in the aim, I think that we'll continue every day to crying that today it's SID, Trump. I don't know tomorrow, perhaps European Union also will decide. I don't know how we will face it. Let me give you an example. I was at North Kivu last year, North Kivu at the camp for IDPs. MSF was making a clinic in the biggest camps for IDPs. Can you imagine? All key population wasn't involved to this implementation, to these activities. I was there, a biggest clinic. I was surprised to see this clinic. The biggest clinic will take care of Mpox this time, Mpox, I think you know. But the key population, the community, wasn't involved in this program. Can you imagine? As a consequences, many of them wasn't to come to assist to these activities. They wasn't to come to participate to take care. They wasn't to going there. That's why it's important. I know you have also a plan, MSF. You have a plan, you have a program, but involve local organization to your program, work with them. That will help also to attend our goal to all of us 2030. I think that is our all over 93%. Thank you for giving to me this time.
No, I think that's a very good point. In these times where we are facing lots of crises, conflicts increasingly, it is important also in those difficult circumstances to make sure that communities are involved, key populations also, in order to provide the best services. I think it is a very rich conversation that we have to continue for sure. I think the adaptations, one of the things that I take also from it is that, yes, there is a need for adaptations, but the question remains, with what speed can we do that adaptation and to what extent without causing more vulnerability, more deaths, sacrifice some of the gains that we have made, and make sure that the people that need their HIV treatment are not excluded or really are facing impossible barriers. So, yeah, we've run out of time, unfortunately. What remains? Yeah. Is there still any question from the room for the people who were brave enough to come in spite of all the transport problems we have here in Brussels? Anybody still? No? So I'm sure you all have more questions still, and we should continue the conversations on that. But first of all, I want to thank all the panelists for their interesting and inspiring contributions. I need also to thank the translators. I hope we didn't make their job too difficult. And everything that has given the technical support that made this possible. And everybody online and in the room that joined the discussion, thank you also. I hope you found some extra information and motivation also to continue to engage in the fight against HIV and AIDS and support people living with HIV that are facing still now enormous challenges, and especially in these difficult times. So what I take from the discussion is that I just want to reiterate that we know that AIDS is not over, and we need a continued meaningful support. Critical resources are part of that, and innovative strategies also. More than ever, I would say. And so let's continue those conversations, and we gather ideas, and we gather arguments, and we gather, hopefully, support for action and adaptation. A good evening for everybody, and thanks again. Yeah, Crystal, you are still online, Crystal? Yes, I see. You have the last word.
I am, but I will not take more time. Thank you, everybody, for listening in, getting inspired. Thank you to the panelists, for channeling these questions and conversations. And let's continue this dialogue, and let's continue finding solutions, because that's also what we're good at sometimes all together. Let's keep on believing that. Thank you. Have a good evening, afternoon, good day. Bye.
Bye, everybody. Thanks.